Manager at MedSynapse. Today, I'm honored to introduce our esteemed panel, a gathering of luminaries in the field of diabetes care and advocacy. First, please join me in extending a hearty welcome to Dr. Manisha Gupta, a clinical associate consultant at Center for Diabetes and Endocrine and Regency Hospital Private Limited, Kanpur. She was awarded the prestigious USV Award for Best Innovation in Diabetes Care in Challenging Situations in 2020, showcasing her commitment to improving diabetes management. Welcome, Dr. Manisha. Now let's warmly greet Dr. Rutul Gokhlani, a consultant diabetologist and a managing director at AHC Diabetes Center, Ahmedabad. He's a governing council member of the Diabetes Pregnancy Study Group of India and is the national coordinator for DGNS Group of Diabetes India. Dr. Rutul's expertise extends to managing technology in type 1 diabetes mellitus and gestational diabetes mellitus. Welcome, Dr. Rutul. Next, a heartfelt welcome to Ms. Melissa Holloway, founder and CEO of Smart Start Health. She's a patient advocate and diabetes care industry consultant based in London, United Kingdom. She has 2 decades of experience in diabetes care industry and has collaborated as a co-author on numerous peer-reviewed journal articles and contributed to clinical guidelines in the field of diabetes technology. Welcome, Ms. Melissa. And a warm welcome to Dr. Amit Kumar Dey, a consultant physician specializing in diabetology, obesity, and metabolic disorders. He has received numerous accolades, including the Diabetes Award Awareness Initiative Award at Diabetes India 2020, the Voluntary Faculty of the Year Award, IMACP India Chapter 2022, and the JPEF 2023 Award for Improving Diabetes Care Through Technology Innovation. And leading today's conversation with skill and expertise, we have Ms. Mehek, a type 1 diabetes lifestyle coach and a visionary founder of Unstoppable Type 1 and Diabetes Pathshala. Her mentorship has touched the lives of over 400 individuals with diabetes, offering transformative lifestyle strategies in collaboration with medical experts. Welcome, Ms. Mehek. With this exceptional panel of experts, we are poised for a truly informative and inspiring discussion on the management of type 1 diabetes. Before we dive in, I would like to mention that we encourage your questions, so feel free to drop your questions. Also, this webinar will be recorded and will be available on the MedSynapse after the live session is over. Now, I would like Ms. Mehek to guide the conversation from this point forward.
Thank you, Dr. Harshita. First of all, I'm honored that I'll be talking to all these prestigious, honorable doctors. And I have a lot of questions to ask, a lot of things to understand, and I hope I'll be able to do justice to this session. So I'll start the discussion without wasting much of the time with question 2. First, let's go to Dr. Amit. Dr. Amit, you have been in this field for a long time. So this one very common question keeps coming up again and again, that if one sibling has type 1 diabetes, then does it mean that other sibling will also have type 1 diabetes?
So thank you for the question, Mehek. And before we kind of dive into that question, we need to understand one thing, that type 1 diabetes is, it is carried genetically, but it's also a polygenic disorder. So there are multiple genetic factors which are involved. Just genetic factor, there is also a lot of environmental factors that triggers the incidences of type 1 diabetes. And I think there is a lot of gray zone in that as well, because we still do not know the exact environmental triggers that can stimulate, an individual to develop type 1 diabetes. Now, what your question is, that if one sibling has a type 1 diabetes, what are the chances of the other sibling getting it? Well, it is definitely higher than that of the general population, but it does not mean necessarily that if one sibling has, the other sibling will definitely have type 1 diabetes. There was one study that was published by the ADA which says that the chances of the sibling getting type 1 diabetes is about 6 to 7%. But again, that's a very variable number and it is very individualized. Like I said in the beginning, that type 1 diabetes is a very polygenic disorder. And I say it would also just not vary upon the genetic factor and the genetic predisposition or the genetic history of the family, which will largely govern the occurrence and the incidence. It will also depend upon where you belong to. Like, for example, you will find a higher incidence of type 1 diabetes in the Western population or in the Caucasian population as compared to the Asians or the Southeast Asian population. So your ethnic origin will play a very important role at this point of time, the genetic factors, and then the environmental triggers will also play a cumulative role. So all this will determine whether the sibling will get a type 1 diabetes or not, but it cannot be an absolute point to be taken. But yes, if one person has got type 1 diabetes, then compared to the general population, the sibling will definitely have a higher risk, but not an absolute risk of getting type 1. Mehek.
Thank you, Dr. Amit. You have beautifully explained it, and I hope that will question a lot of that will answer a lot of questions that people have. Now, you said that it is genetic. There are some genetic factors and some environment factors, and with that, I move to my next question, and this will be to Dr. Rutul. Sometimes with type 1 diabetes, there's a lot of confusion as to what kind of type 1 do I have? Do I actually have type 1? Do I have type 1A, type 1B, or do I have MODY? So I want to know, should all type 1 diabetes should go for MODY test or we should avoid it?
So, Mehek, this is actually a wonderful question because it's quite a big relief when it is not type 1. So, whenever we are suspecting if it is MODY, then definitely we should go for genetic testing for MODY. But the simple answers are very basic. That a few of the tests, the basic tests like what we check for ketoacidosis, the serum acetone level when the patient was diagnosed, or the patient ever had any ketoacidosis or ketosis. Most of the cases of MODY, they don't get ketosis or ketoacidosis. The other thing, the commonly done report here in India, it is C-peptide level. I would say that yes, antibodies we don't do that commonly. Yes, the most common antibody that we do in our practice is GAD antibody, but other antibodies are not so easily available, especially in tier 2 cities or smaller town. We don't have this reports done. So the common test which can be helpful to differentiate between MODY and type 1 diabetes is a C-peptide. First of all, we need to check that C-peptide level. If it is insulin reserve is there, then definitely the chances of type 1 is very less, and chances of MODY could be there. So again, nowadays we are seeing commonly type 2, young onset type 2 diabetes, and LADA as well. So MODY usually comes between around age of 15 to 30 or more than that, around maybe 20 to 30 years of age. This is the common age. But for type 1, most of the cases are less than 20 years of age. So this is how actually we have to differentiate. There are multiple factors, though the ultimate answer is genetic testing. But in most of the cases, we do not need to do this genetic testing, and we can diagnose by the simple history and basic reports.
Okay. So, Dr. Rutul, thank you for telling that it is not required in every case. It gives a lot of clarity. And now, with that, I have a follow-up question to Dr. Amit. Dr. Amit, now see, obviously the genetic factor is involved and lot of environmental factor is involved. Plus, we can rule out MODY. But I want to know, if a parent has type 1, what are the chances of child having type 1?
So this again, you have to divide this question into kind of two sections. One is if both the parents are having type 1 diabetes, then there is a much higher chances in the child to have type 1 diabetes. But again, that is not 100%. Okay. Either of the parents have type 1 diabetes, then the chances of getting type 1 diabetes is higher as compared to that of the general population. But again, you can't take it as an absolute figure. But in case of MODY, which Dr. Gokhlani just spoke about, and you must remember that family history, strong family history, is one of the biggest suspicion of MODY, because most of the people will have a family tree having the history of the disease. So that's how you differentiate MODY from type 1 based on the family history. In type 1, the family predisposition or the genetic predisposition may not always be absolute, but yes, if both the parents is found to have type 1 diabetes, then the child will definitely be having at a higher risk. If one of the parent has it, then the child might have it compared to the general population, a higher risk. But again, the environmental factors, the lifestyle factors will play a very important trigger in at what time and how often, how quickly the child can develop type 1 diabetes.
Thank you. Thank you for sharing that.
And also one thing I should add here, and I think we will talk about this when Dr. Gokhlani speaks about it a little later, is that when an individual with type 1 diabetes is getting pregnant, how good the metabolic control is, during pregnancy plays a very important role as to what metabolic memory the child is carrying. And that too plays a very important determinant factor in the child being born or developing type 1 diabetes at a later stage.
Right.
I think later, yes.
Yeah. Thank you. Thank you. So I would have loved to move to the pregnancy question, but before that, I want to ask Melissa. Melissa, you are from UK and you are seeing a very different world from what we see here in India. So in India, we see a lot of resistance to technology. People don't want to put insulin pump because somebody will judge them, and kids don't feel comfortable. In fact, I've heard somebody saying that we should not put kids on technology because they get addicted to technology. So I want to know, do you see similar approach in your country? Do you go through similar resistance?
What a good question. I would say things have been very different here, possibly because we started with the conversations about diabetes technology in pediatrics and adults quite a number of years ago. In 2003, we had the first criteria for who within the NHS in England and Wales ought to have funding for insulin pump therapy. So we've had over 20 years of the NHS saying this is a priority, and that has influenced a lot of people's attitudes over time. The 2008 criteria are the ones that we still use for funding in insulin pump therapy. And soon we will have criteria that are specific about hybrid closed loop. What we have seen in terms of access to pumps is that overall, around up to 40% of young people up to the age of 18 access insulin pump therapy. And among people who are over 18, the number is a bit lower. But as those people are aging up, the number of people who are going to be in their 30s, 40s, 50s who have an insulin pump is steadily rising. So there was more resistance among the older population who would say, well, I've been doing what I'm doing for many years. I don't see why this is going to make a big difference. On the other hand, some people became very clear about their priority on getting access to an insulin pump, especially if they had a history of severe hypoglycemia. So those things have shaped our trajectory when it comes to pump access. As regards CGM, actually, we have some very different data, and I was going to share my screen, but then I realized I do not have the button, so I shall just quote. I pulled up an interesting slide that was shared by someone whose name may be familiar, Partha Kaur, who's been a real advocate for access to CGM in the UK, and I know he's had some work on the ground in India as well. There was a recent tweet from him quoting the ethnicity of people in England who have been offered a CGM, who are eligible for it, the patients who have therefore been prescribed it, which is a little bit lower, and then those who declined. And what we have in terms of data is that over 90% across the ethnicity categories were considered to be eligible for funded CGM, type 1 diabetes. And then around just a couple percentage points lower, so between 87 and 92% actually were prescribed. This, when I say CGM, I mean particularly the Freestyle Libre system or perhaps Dexcom ONE. The other types of CGM that we have on the market are accounted for in different cost structures. But this is how prevalent the tech has become. Those who declined, the numbers are actually between 12% and 4%. So we have seen very little in the number of people who would say, no, just don't want it, not having it. And I think a lot of it has to do with, because it's been 20 years that people have had time to get used to the idea of the pump being something that someone might wear. And then the CGM has come up over the last 10 years because we started talking about it quite a long time ago. And some cost structures have only recently changed, but there's been demand because people had access to the information about how transformative it might be. Stigma does still exist, and I do see plenty of posts on social media in UK forums around a child who doesn't want their device to beep when they're at school because it will draw attention to them that they don't want. So we do see some cases where parents and children make a deal that the child will wear a phone that will pick up their CGM data on a belt under their clothes while they are at school, so nobody knows they have it, and they use a smartwatch to look at their glucose levels. And at that point, they have some more discretion and control about how those alerts might draw attention to themselves versus them being aware and their caregiver being able to see what's going on with them. So I hope that sort of answers the question.
Yes, that does. So thank you so much, Melissa, for sharing that. It gives me hope, like Parthakar is doing in in UK. Dr. Manisha, Dr. Amit, and Rutul will be flag bearers for India. Definitely, they're already setting a high hopes for us. They're getting technology. They are making people use technology. So I do see that similar things happening in India. We may take time, but definitely it will be there. You have given me hope. So thank you so much for sharing that. And now I'll move to Dr. Manisha. Dr. Manisha, you have been sharing a lot about, you have been recommending a lot of insulin pumps. You have known for adapting technology. So I want to know, one common struggle people face is carb counting. In fact, today I was talking to somebody and the person is from a small town and she said that we are told that why do you want to learn carb counting? Just go with the fixed dosage. So I want to know what problems do people face when they're learning carb counting, or if you have any trick to share with them.
Thank you, Mehek, because for the question, and the question becomes very tricky because carb counting itself is a big topic to discuss for sure. And carb is like any patients who are diagnosed with type 1 has to learn carb. The carb exchange is very important. And when I did my Alan Resch fellowship, I did from Cleveland. And one of my fellow colleagues, he did from Australia. And there he learned they use a swim technique that stands for success with individualized insulin standards. And they give them a card, which is a personalized card without fixing the dose of insulin. That's like short acting insulin. And they're supposed to take as per their carb exchange. So without learning carb, you cannot take your boluses for sure. So they calculate it as per the base, as per the body weight, and then they make a card with a per exchange, card per exchange, and I'm sure it has helped me a lot. Your program also does wonders in that case. Even your meal, your activities, your fruit plate technique, and all helped better. So carb is a very important ingredient to understand the type 1, and their dosing is very important. So carb exchange has to be adapted.
Thank you, Dr. Manisha. You have talked about a very interesting technique, swim technique for carb counting, and I would really like people to learn about it from you, because I've seen it. I've seen your card, and it's amazing. It simplifies the entire concept of carb counting. So thank you so much for sharing it with all of us. Now, with the same thing, I move to Dr. Rutul. We were holding back the question on pregnancy. So a lot of my type 1 friends are now getting married or planning to be pregnant. And they have this question that can a female with type 1 have normal pregnancy? And if yes, then what are the best practices do you suggest so that endo and gynae can work together for their benefit?
Yeah, right. Very important question. First of all, you're talking about should type 1 diabetes go for normal pregnancy or not. But the biggest problem in India, what we are facing nowadays, is should a type 1 diabetic person with type 1 diabetes should get married or not? This is what the basic question is, and we have come up with like. Will be they able to survive? Will they live for long? Then we'll plan about marriage, and then then pregnancy. So this is very basic question and understanding that yes, they can go for normal pregnancy. But the problem is the commonest problem what we face is like accidental pregnancy. This is very common thing in type 1 diabetics. Not only in type 1 diabetics, most of the pregnancies are accidental pregnancy in our country. It is not planned ever. And the problem we face as a diabetologist, as a gynecologist, or as a healthcare professional, what we face is they come up with HbA1c of 9, 10, 11, or sometimes 13, and the ball game is in our court now, in diabetologists' court, that how we should treat. Should we continue the pregnancy? This is the first question from our gynecologist colleague. And definitely we take the chance in many of the cases, even after HbA1c of around 10, we take the chance, they successfully deliver. But the common practice in India, what we follow is that the most important thing is monitoring. When they keep monitoring better, like in the common thing in India is like for 3 to 4 times random blood sugar they check in a week. It is not commonly checked that fasting blood sugar or post meal or pre-meal, they don't check it. But for pregnancy, it becomes easy. Patient become more compliant, so it is also easy for us. And so monitoring is important part. And the other beneficial thing apart from compliance is that hypoglycemia rate in pregnancy is very low. Patient becomes so much adaptable. They adopt that hypoglycemia so well. So like even their fasting blood sugar is around 70 or 80, they don't feel hypoglycemia. So hypoglycemia threshold goes very low. So this is in favor of type 1 with pregnancy. So definitely we can go for a normal pregnancy. But in our gynecologist obstetrician friends, they elect for cesarean section in those females. So yes, they can go for normal pregnancy.
Thank you, Dr. Rutul. You shared a very, very interesting point about accidental pregnancies. If I can paraphrase you, you said that if we are planning the pregnancy in type 1, by managing our HbA1c, then gyne and endo can work together to help them have a normal pregnancy. You have shared the most important point, which I would take away from here and share it with my community also, and with my all friends who plan to get married, that it's important to plan rather to wait for an accidental pregnancy. So thank you so much for sharing that. And now,
Mike, can I make a quick point regarding
sure.
this particular topic?
Yes,
so basically, this is a very sensitive thing, and that is lacking in our practice in our part of the world. That is preconception counseling, and I think that is a very important entity which Dr. Rutul just spoke about. And this is just not for the type 1s, but it's also for a type 2 diabetes going into pregnancy. That because of the lack of coordination, interdisciplinary coordination, as we can say, or a timely reaching out to the first point of contact of a patient is usually their primary care physician. In our country, it's usually their primary care physician. And from the primary care physician, the patient gets referred to a diabetologist or to an obstetrician and gynecologist. So I think that is where the awareness of preconception counseling is very, very important. And I strongly believe, in fact, we even wrote a chapter on this in a textbook, that the first point of contact for preconceptional counseling is not your diabetologist, is not your obstetrician, is your primary care physician. Because that is the person who's going to be in contact, or your family physician. That's where it starts from. Okay, it just starts from the grassroots, and from there because this whole session is all about best practices, and I think this is very important, that we need to encourage all the interdisciplinaries to follow proper preconception counseling. If that is not done, then you will find somebody coming to Dr. Rutul with an HbA1c of 9 and 13, and then we are at the receiving end of controlling the blood sugar, because the individual wants to proceed with pregnancy. Before we go on to the next question, Mehek, since this is a very important thing, I would just like to take Melissa's point of view on.
Yeah. I was coming to that.
Practices in the UK, and how prevalent is preconception counseling over there, Melissa?
Well, these are such important conversations. So there is certainly an attitude among the specialist clinics in type 1 diabetes to have a preconception planning discussion. But because we only see the adult diabetes team probably once or twice a year, and priorities can change in between those visits, we do still have around 50% of our type 1 pregnancies are unplanned. And that's a real big number, right? In a place where it should be more accessible to get preconception care. And for quite a few years before I was personally ready to start my family, because I did pay very close attention to my glucose levels, I'd get the question whenever I saw a diabetes care professional, are you planning a pregnancy? Because we never see women with numbers in this range unless that's what's on their mind. And for several years, I had to say, no, seriously, I'm not. I just am managing my diabetes very carefully, because when that time comes, I don't want to have to adjust my lifestyle and how I manage my diabetes radically in order to be healthy, to have that opportunity. They were astonished by this. I said, this is because I've been working in this industry so long. I've been going to so many conferences. I've seen too many presentations about pregnancy and diabetes to think that this is not relevant to me. I knew it was relevant to me. But among my friends, there's, and I got a text a few weeks ago from a dear friend who's thinking about starting her family. And she wanted to say, well, how should I approach this preconception clinic appointment? I don't know what to expect. What kinds of questions are they likely to ask me? I think maybe I'd like to get an insulin pump as I get into preconception planning. What should I be prepared to discuss when it comes to choosing an insulin pump, or what questions will the doctor want me to have an answer to? And I thought, wow, I'm glad she felt she could trust me to ask those questions and that I would have helpful answers. But she's an extremely bright professional woman. And for her to feel like there are barriers to getting the care and support, or that she might feel put on the spot, or she might not have the right answer, tells me that we have still a long way to go in terms of people feeling generally like, I'd like to have a family. What should I know? How shall I begin? Will be important conversations that they can have with their team. So I would say we're doing a bit better than we used to. We have, as part of the approach to providing CGM in the UK, before the criteria were expanded as far as they have been for many, many people with type 1 diabetes, we did have a priority on all women with type 1 diabetes being offered CGM in pregnancy. And that has definitely made a difference in how people can safely reach their HbA1c targets, especially if they have started from a rather higher number. And it's something which is easy to check remotely. The diabetes care team can log in if the patient is sharing their data digitally and see what went on last week and make dynamic suggestions about how to adjust their insulin without that person necessarily having to come in for a clinic visit each time that they need to have a conversation.
So yes, therapeutics definitely make a huge impact, when you're monitoring in pregnancy. The other thing that is something which is also lacking in our community is the joint clinic by an endocrinologist and an obstetrician at the same time. And having said that, from my experience, clinical experiences, I've found that a type 1 diabetes would probably be better prepared to go into pregnancy than a type 2 diabetes in terms of the orientation and all. I mean, that's just my clinical viewpoint, but I would love to hear your views. But back to you, Mehek.
Yeah.
So,
Dr. Amit, you have given a very good food for thought of preconception counseling. And I know in Delhi, at least, we have now clinics where a diabetologist, gynae, and obstetrician all are sitting together and working. But I still see that preconception counseling is still missing. And that is a very good food for thought. And I know a lot of doctors here are listening to this. I hope you take this from Dr. Amit. And if you can implement even 5% of it, you will impact a whole lot of type 1 females and not only they, but their future generation will also be thankful to you. So now with this, I'll move forward and we'll talk a little about diabetes technology. So now coming to Dr. Amit, what's the appropriate age to start pump therapy? Because I've been hearing, we generally recommend pump therapy to different age group, and parents say that my child is only 10 years. Can he take care of pump? My child is only 6 years. Can he take care of pump? So according to you, what is the appropriate age to start pump therapy?
So I will not give you a clear-cut age at which you start. Rather, it all depends upon how quickly the family and the individual can adopt to the principles of an insulin pump therapy. We just had Dr. Manisha speak about the importance of carb counting and adjusting, the insulin carb ratio, etc. So it requires a lot of training, retraining, understanding, discipline, and adoption. So I think if you look at the pediatric age group, you can start insulin pump even in the younger age group, provided you have got an understanding parent who is willing to devote the time to monitor the child for the pump. And as the child grows up, you train and you retrain the child in how to take care of the pump and how to do the necessary things. I think in our practice there are usually the limitation of pump therapy, which we have seen in practical term, is the continuation in terms of the cost and the complexity of using the pump. I think these two become limitation, right?
Right.
If you look at our Indian community, I think most of the type 1 children are started when they're in the adolescent age, if not much earlier. If the parents are compliant and if the parents are focused and oriented enough and they are under the guidance of the right pediatric endocrinologist or a diabetologist guiding them right from the go, then pump therapy is the best possible option for any individual at any age group. But having said that, it requires a lot of discipline. So in our community, we'll see most of the pump users start from the adolescent age group, wherein you're actually training the child and you're kind of imparting them with education of how to take care of the pump and inject themselves and etc. and monitor their blood sugar. And if they're using the higher end pumps, how to take care of their CGM, etc. But it lot depends upon that. Now you look at the adult population, like a few weeks back we had one patient initiated on pump therapy in one of our clinics, and that patient was on just multiple daily dose of injection for 27 years of her life, and then she decided that I'm going to go with the pump. Her husband was comfortable enough and was supporting enough to put her on the pump, and more so because they're going to plan pregnancy. So that comes the concept of preconception counseling. So see, there is no particular age bar here, but earlier the better, but you need to do it in a proper way. That is very, very important, rather than doing it hastily and then being lost to follow-up. That's again a big negative point that we find in our country, that patients are lost to follow-up and it's very difficult to track them. So that becomes a big limitation, especially when you're on the pump. So right from the word go, as a doctor, when we should encourage a patient to use pump, at least that should be one of the treatment options offered to them. That's number one, right? Because that's the best possible option. Depending upon their financial capabilities, their ability to understand, and their ability to continue, in the younger age group, it's going to be the parents who are going to be taking care. Then in the adolescent age group, once the child matures, it's their own responsibility to take care. And in the adult, of course, you can start at any point of time. Based on the individual capabilities, you can initiate the patient on the pump. But most important is training, retraining, helping them to adopt, and again, making sure that they're not lost to follow.
Right. Thank you. Thank you so much.
May I add the point?
Yeah,
Please,
doctor.
So it is very important to learn about, approval for insulin pump initiation is at age of 6 for any pump. But the youngest a kid when I initiated was 4 years, as I took the consent of their parents that they want to go for pump. So it's definitely individualized, but as rightly said by Dr. Amit, that you should think of family, how family can easily adopt this all stuff, because using CGM and pump and carb counting, everything, when our patients are not even ready for taking 4 basal bolus shots, and we have to convince them for carb counting and active insulin dose and everything. And I'm talking about the insulin pump, which was quite before 3-4 years, when it was not 780G. It was very basic pump that did not calculate a bolus dose or basal dose itself. So it was not automated system. So yes, definitely we have to explain it to patient that yes, it's just we are reducing the prick. Otherwise, you have to do it yourself. Many of the things.
Right. Thank you, Dr. Rutul. Yes, that's true. In fact, yesterday only I was talking to Medtronic's team, and they said that with the consent of parent, they have started with a 2-year-old child also. So in India, the youngest child is now 2 years old who is on insulin pump. But like you rightly said, my first question to family is, can you afford it? Because I don't want them to go on to it in haste and then later on take the child off the pump. So I prefer to tell them the cost first involved, and then the right mindset of understanding carb counting, and then I follow this approach. So thank you so much for sharing the right approach and right methodology that needs to be put forward while we introduce the pump. And like you said, it is important as a doctor to tell them what the best technology is available rather than just starting on with pen. So I even heard one view which I would like to share, and I would like to know your opinion. There was a view which was shared by one of the parents with us, was that a child should first practice to be on syringe and then put on pump. So I want to know, what are your views? Is it required? Is it not required? I have a very different view, but first I would like to know your views. So
Should I go for it?
Yeah.
I don't think that we should go for syringe nowadays in India. In Ahmedabad, at least, I don't see most of the patients using even syringes. They have pens. Yes, we can go for pen, and if this is our responsibility to explain them, as you rightly said, Meg, we should explain them. This is what available thing, the best available thing in India, and you should go for it. If they can afford it, then they would go. Why should we explain syringe only? And it is definitely not necessary to explain the basic, too basic, because after a few years, maybe down the line 5 or 10 years, we'll not have syringes. We'll be using only pens, as we are not seeing many of the things which were in past before 15-20 years. So why should we think of what it was history? We should think of a future only.
Right.
See, the secret of managing a chronic complicated disease lies in the process of managing it in the simplified way. When you are kind of teaching a child of how to take care of your type 1 diabetes, the more complex you make it for the child, the more resistance and resilience you will kind of face from the child right from the word go. So if you teach simple procedures first, get the individual adapted, I think the acceptance will be more. Because it's a lifestyle disease, it's going to be a lifelong disease as well.
Yeah.
So you give this. Now, again, when you talk about what is simple for me may not be what is simple for you, and vice versa. That varies person to person. Someone find adjusting a pen more complex just because they feel that it is more complex because they don't have the right training, and they feel just pulling it out of the syringe is much more easier. So it's just a perception, it's a relative perception. So right education and giving a basket of option is also very important. We should not be rigid, I would say. We should not be rigid. If somebody wants to start off with a syringe for what I would say, for the sake of experiencing it, and they feel that I'm comfortable with it, you can give them the options and say you can start off with it, but I'm eventually going to put you on the pen because this is the right possible option. And then if you can afford, you can go into the pump. So I think that's the simplicity should be taken into account when we are counseling the patient on this.
Right, definitely. Melissa, what are your views in UK? Do you prefer a person to first go on pen or syringe and then to pump, or the person can directly go on insulin pump?
That is a very good question. We generally do have people on pens for at least some time, even if there's a movement from the team saying, owing to this person's insulin sensitivity, they should be on a pump. There will still be some sessions of education that they go on before they actually are handed the tools. And it does take a few weeks for the funding to be agreed and the product to be shipped to the patient. So there is a little bit of wording in the 2008 insulin pump funding criteria from NICE, our National Institute of Healthcare and Clinical Excellence, around children should be expected to undertake a trial of MDI therapy in their teens. But that was actually written with a forward view that, well, what if we did start putting children on a pump at diagnosis? And in practice, we very rarely do that in the UK. I've only heard of a few situations where a child was admitted to hospital with a new diagnosis and then went home with an insulin pump. It just doesn't seem to be what we do here. We're doing more of that with CGM now, though, rather than insisting that somebody does finger sticks for a period of months or weeks before they get their first sensor. There's a much more proactive attitude about starting CGM, and it's still instructing the family, the child, in how to do finger sticks, because there will be moments when you do need to. And if the only way you know how to monitor your glucose is with a sensor and you're not able to put a new one on right now, or you're in a warm-up period and you need to make an insulin dose decision, what you must know how to do a finger stick, even if it's backup. So I did recently hear of an adult who went on holiday to another country with only CGM sensors and no finger stick, and his last sensor fell off when he was at the beach, and he was issuing this urgent SOS call on Facebook. And I thought that was a bit silly. Like, really, you really would not go out when you know that it could rain in England. You wouldn't really go out without an umbrella on.
Right.
So I thought we do need an attitude around, even if we do primarily use one form of tech, we need to know how we go back to the other one, even if it's for a short term. One thing I have observed as well, though, among the pump using population, and we have children around the age of 2 starting on pumps. That is absolutely par for the course when a child has been diagnosed at a young age. One of the major things about dealing with toddlers and their appetite is you don't always know if they're going to eat everything. And for many parents, the idea of having to give a dose of insulin and then the child walks away from the table, isn't going to eat that meal, and then you're trying to feed them something sugary to meet the insulin that you already dosed them is a very scary thought. Also, waiting until they finish their meal to give them any rapid acting insulin allows so much time for their glucose level to rise that may not actually be the safest idea either. But with a pump, they can more easily give a little bit up front for what they're pretty sure their child is going to eat. And then if they need to, they can top it up more easily later without a second injection. And that can make a big difference in the child's experience and their acceptance of living with diabetes at a young age. So I've definitely seen that as a major reason why parents want a pump for their small child, is so that the meal times are much less stressful.
Right.
And the activity is easier to manage.
Yeah. Thank you, Melissa. Melissa, I saw that Facebook hue and cry about the person you are talking about. I was active there. So yeah, definitely I agree that they should know how to manage in times when they don't have anything. It should not go like I need to run to the pharmacy in the mid of the night to get another CGM. So I totally agree to what you are saying. And to usage of a pump, what I tell parents is, you would, while you are handling your child an iPhone, do you say that my child should go on a trial of a landline? If we can directly handle the child iPhone, why not an insulin pump without giving them a syringe or a pen? So that's what my views are. And with this, I'll be moving forward to the last question to Dr. Rutul. Dr. Rutul, there's a lot of dengue, malaria, and flu season. And so I want to know, what are sick day rules we should follow or we should give to our type 1 clients?
Yeah, so there is very high variability in sick days. When a person with type 1 diabetes is sick, definitely the blood sugars are going to be very high. But in few of the cases, when there is dehydration, when in the condition of diarrhea, So in such condition, patient may have hypoglycemia as well. And in some of the cases when patient can't eat, have a lot of vomiting. In such cases, patient may have hypoglycemia as well. So we should take care of both the things. So for that, monitoring, frequent monitoring is the option. And I would say that for anything, for any, like even it is pregnancy, it is type 1 diabetes, it is sick days, every time the answer is monitoring, and the proper monitoring is more important than anything. So definitely that time when if the blood sugars are very high, then we should give regular correction doses and frequent correction doses. If patient is using insulin pump, then there is not a problem. But yes, in MDIs, definitely we should take care of frequent injections, pre-meal injections or correction doses. The other thing we should take care of is ketoacidosis. This is what we have commonly seen, that in sick days they have there is very high trending of ketoacidosis, and in such condition we should ask patient to keep urine ketone strips, and if it is possible, then go for acetone or any other test for regular testing. So this is more important. And the other thing, what I have commonly seen in the conditions like pneumonia or in such condition, that steroid usage is increased. So we should be aware of this thing, that steroid may cause hyperglycemia, severe hyperglycemia. In such condition, we should be more, we should take care more, especially monitoring and correction doses.
Right. Thank you, Dr. Rutul. What you said was very important. Especially, we need to see what kind of disease it is. Like, if the child is dehydrating, then the sugars may go low. If there is flu, the sugars may go high, and if there are steroids, the sugars may go really high. So, before I pass it over to Dr. Harshita so that she can take question from the participants, Dr. Manisha, would you like to add something to what Dr. Rutul has shared regarding sick days management?
Yeah, monitoring is the key, as he very well said that. So if the child or the adolescent suffering from any kind of illness, like I'm having it right now, so monitoring is must, and proper fluid intake is important. Correction dose is uttermost important, and nutrition. They should, yeah. So nutrition also plays a major role. Especially they avoid fruits and all, but they usually can eat fruits. Especially diabetes, wherever any patient, any child comes with, now everything has been stopped, especially fruits, and the child cannot eat. But that's not the case, and the child can eat whatever the child really wants, because that nutrition is important for the growth as well. So sick day is a crucial time for the child and the parent as well, because that adds on to a lot of anxiety to the parents. So monitoring is the key. Maintain hydration and correction dose. These three things I would just add on. Thank you so much.
Thank you, Dr. Manisha. So hydration, a very, very important factor to let the infection flush out of the body. And like Dr. Manisha said, that most of us tend to leave fruits the first thing. We need to understand that the most important nutrients and vitamins which we need during illness we get from natural source, that is fruits, we tend to leave. So thank you so much, Dr. Manisha, for adding that. Now I'll hand over to Dr. Harshita so that she can take the questions from the participants and ask us. Thank you.
Yeah, so there's one question. Can you explain the importance of personalized diabetes care, and how can I actively participate in tailoring my treatment plan?
Okay. You want to take this? Anybody who wants to take this?
I think Mehek should be the right person, because she is a lifestyle coach and she has been kind of advocating personalized diabetes care. So you should be the right person to answer on this. And then maybe Melissa can shed some light, because she's working with some smart technologies on personalized diabetes care.
So first, thank you, Dr. Amit. So I strongly believe in personalized diabetes care. And if somebody wants to start with personalized diabetes care, it's important to monitor ourselves. So when I started my personalized diabetes care, I started monitoring myself, and it may be with CGM, it may not be with CGM. With CGM, definitely the best thing. But even if it is not with, if the person is resistant to use CGM, There has to be a proper tracker in place where you are tracking what you are eating, how your sugars are responding, at what time the sugars are responding differently. Once we have all tracked all the data, we know what changes we need to make in our insulin dosing. Once we know about the insulin dosing, we have made insulin dosing, then we go to the food and understand, okay, this food is still not suiting me irrespective of making these changes. Then once the food has been taken care of, insulin dosing and data has been taken care of, then we go to what other kind of insulin can we try on my body to see to get a better result. So I strongly believe in personalized care, and it all starts not with the doctor. The first thing we tend to do is we blame the doctor for the personalized care. Doctor is looking out for thousands of clients. Personalized care starts with us. It's our body. We need to understand ourselves better, and that's what I teach and propagate, that learn about your body. Once you know about your body, you can talk to doctor. We don't even know what's the right question I need to ask my doctor. Generally we tend to go to doctor and say, my sugars are coming high. How will he help? What time your sugars are coming high? What is happening? What are you eating? Do you have the data to talk to the doctor? So that's the thing which I strongly believe in. And now Melissa can tell the importance of CGM for creating the personalized care plan, since she is the expert on that. Over to you, Melissa.
Well, thank you. I absolutely agree with everything you've said just there. I would add that there is another step I would suggest the doctor to consider, which is at the beginning of the appointment, just to take a moment, really look a person in the eye and say, and how are you today? And just that moment of understanding between two people can be really powerful, because some people come to their appointment very worried, and whatever might be on the table to discuss about their clinical situation, they may not be able to absorb that information because they are in a really stressed state, and actually understanding, actually, I'm really having a hard time right now. Oh, there may be some diabetes distress. There may be some diabetes burnout that's inhibiting their ability to do the things that they know how to do. And you can talk to people a lot about the same priority. But I like to say it's kind of like if somebody has, say, thyroid deficiency and they really want to lose weight, they've gained weight, their thyroid is underactive. They can exercise as much as they could, as many hours of a day, but their metabolism is not going to work right because there is an underlying defect that we need to deal with. And for people who live with type 1 diabetes, the psychosocial impact can be so big that it makes a big difference like that. So in my approach to personalized care around CGM, I've included in the Smart Start CGM content that's going through proof of concept testing some discussions where the healthcare professional does say, all right, let's look at your numbers and see how things are going in terms of, what can I see on the CGM? And then in their conversation, they do uncover that the patient has an attitude, or there's a stressful situation that's going on at home, which is part of how they are self-managing, or they have a belief that they can or can't or should not do something, which might not be the only truth. It might be that that's how they understand the world right now, but you could shift it. For example, somebody who says, I really don't believe that I can eat carbs at night because if I do, my blood sugars will stay high till morning. And they may not actually enjoy their meal with their family. But maybe if they actually had a deeper understanding of how to dose for the mixed meal where they are eating those carbs, they would be able to share that meal and enjoy it with their family, and there would be more harmony in their household. So, and then when they wake up in the morning, they would have, a glucose level that's closer to in target, and they would not be spending the day waiting until it all goes wrong in the evening. Those kinds of things make such a difference. Seeing success and then being able to say, I can do this, that works. Begets success in self-management.
Yeah, very important point, Melissa. Creating the right space to share their experience also counts, definitely. Thank you for adding that point. Yeah, over to you, Dr. Harshita.
Yeah, thank you. And now we have arrived towards the end of today's session. So I want to extend my heartfelt gratitude to all our panelists for their valuable insights on this critical topic. And a massive thank you goes to our engaging audience for joining in and participating actively. So thank you so much for everyone for joining us.
Thank you. Thank you.
Thank you.
Thank you. Good night.
Thank you.
Thank you.
you.
Thank you.
The recording has stopped.
All right. So that was good. Thank you.
Thank you. Thank you, Dr. Amit.
Thank you, Mehek. Thank